Welcome to the AGR video article on LI-RADS Ultrasound Surveillance version 2024 document that has been recently published by the American College of Radiology. I'm Federica Vernuccio. I'm an associate professor at the University of Palermo, and I'm the section editor for the gastrointestinal imaging section of AGR. And today I have the pleasure to introduce Dr. Aya Kamaya, who is the author for this AGR video article. Dr. Kamaya is professor of radiology at Stanford University, division chief of the Body Imaging Division, director of ultrasound, and director of the Body Imaging Fellowship at Stanford. She was president of the Society of Radiologists in Ultrasound in 2021-2022, and she's the co-chair of the ACR LI-RADS Surveillance Working Group. Welcome with us, Dr. Kamaya. In order to start this AGR video article, can you please tell us about your clinical practice, including clinical and academic interests, and how you got involved into the LI-RADS steering committee?
Thank you so much, Federica. Really great to be here. I'm also really excited to talk about the LI-RADS surveillance ultrasound, which you just recently released. So I am division chief of body, as you said. And so I do focus on ultrasound in my research and teaching, but I do cover all modalities. So I do ultrasound, CT, MRI, also GI fluoro. So all parts of body imaging. I do have a particular interest in hepatobiliary imaging and also ultrasound. And so that's sort of where my interests have converged with ultrasound LI-RADS. So I was the chair of ultrasound LI-RADS in 2017 when we released our first edition. And then through the years, we've realized that there are some changes that needed to be made. It really did take a lot of research and publications, things that were published in AJR in particular, as well as multiple other high impact journals. That's really changed the way influenced how we want to manage these patients who are at high risk for developing HCC. And so our recently released recommendations in 2024 is a reflection of some of the new knowledge that we have acquired. So I'm co-chair along with Shruti Rogers of the Surveillance Working Group. We have also multiple members from throughout the country, also throughout the world. We have quite a few from international members as well, from Canada and Australia. But most people are actually in the United States, and our recommendations are relatively, I guess they are aligned with the American Association for the Study of Liver Disease, which is a North American society.
Great. And in order to start with, can you please provide a background for the use of the LI-RADS ultrasound surveillance system?
So for the ultrasound LI-RADS surveillance system, it's important to think about who you're applying it to. We actually go with what the American Association for the Study of Liver Disease recommends as far as the surveillance population. So I think that's the most important thing, is that you apply this in the appropriate high-risk population. That's actually determined regionally by individual societies in where you live. So in North America, that surveillance population is defined as patients who have cirrhosis from any cause. And the incidence of HCC in patients who have cirrhosis exceeds 0.8% per year, and that is considered to be cost effective. We also include patients who are non-cirrhotic but have hepatitis B, in whom the incidence of HCC exceeds 0.2% per year. And so that's not everyone with chronic hepatitis B, non-cirrhotic hep B, it's certain subsets. And so that includes males over 40 who are from an endemic country, women over 50, also from an endemic country, persons from Africa at an earlier age, and that's defined as basically starting at the age of 20. people who have a family history of HCC who are non-cirrhotic Hep B patients, and then those who have a page B score of over 10. And that's a new thing that was not previously part of the population, but that is something that the ASLD has incorporated. So the other thing about the ASLD and LI-RADS is that we don't actually include in our target population for application those patients who have Child-Pugh C cirrhosis. And that's because their life expectancy is not long enough to where surveillance would be expected to be life prolonging, unless they're on a liver transplant waiting list, in which case they should undergo surveillance, but it's not clear what modality is ideal for those patients. And so, at least at Stanford, we do MRIs in those patients who are on their liver transplant waiting list. So that's a little bit of background about the target population. And the reason why it's really important to identify that target population and to apply it appropriately is that not everybody in the world is at risk for developing HCC. We do want to target those patients who are at high risk of HCC. And so that is what is determined by the American Association for the Study of Liver Disease, and we are congruent with them.
So, may you please explain why did you feel the need to change the name from LI-RADS Ultrasound to LI-RADS Ultrasound Surveillance?
So the reason why we decided to change the name is because surveillance, we feel, is something that may be done by other modalities, not just ultrasound. It also incorporates serum biomarkers. It could also incorporate other modalities like CTU or MRI. And so surveillance is more of a broad term for what is applied to testing patients who are at high risk for developing HCC. And then within that surveillance algorithm, ultrasound is one component. So that's why we wanted to change the name to LI-RADS Surveillance. So at this time, we have LI-RADS Surveillance, and we have defined LI-RADS Ultrasound Surveillance. Ultrasound is like defining the modality that is utilized for surveillance. And that's why we decided to change the name. Another thing that has changed that is just sort of on the background is we used to say screening and surveillance for HCC, but we have dropped the term screening because it's just a mouthful. So surveillance is really what is a term that is utilized now in place of screening and surveillance. And so that is the rationale for that name change. We also we think that in the future, we would like to propose a surveillance strategy for those patients who are recommended to go to alternative imaging, namely MRI. We think that abbreviated MRI may be an option for those who are not ultrasound candidates, who maybe fail ultrasound. And so in that case, we will have a LI-RADS MRI surveillance algorithm, but that's in the future.
With regard to the LI-RADS Ultrasound Surveillance version 2024, which are the core novelties introduced in this updated version?
So let me go back to just what is the same, and then I'll talk about what's different. So the similarities between the version 2017 and version 2024 are that the three categories, the assessments of the liver are the same. So we have two assessments, the ultrasound category, and then we have the visualization score. With the ultrasound category, we have ultrasound 1 negative, which means that there's either nothing seen in the liver or only benign findings. Ultrasound 2 subthreshold, which means that if we see something that's sub-centimeter, that's not definitely benign and it could be of any echogenicity. Or ultrasound 3 positive, where you see either a finding that is, an observation that is over a centimeter in size of any echogenicity that's not definitely benign, or a focal area of parenchymal distortion, or a new thrombus in a vein, whether it's a portal vein or hepatic vein. So that's the ultrasound category. And there's 3 choices. And then there's the visualization score, where there's, again, 3 choices: visualization A, visualization B, or visualization C. And so the visualization A is no or minimal limitations, visualization B is moderate limitation, and visualization C is severe limitations. And that essentially communicates the expected level of sensitivity. So that has stayed the same. With that as the background, the things that have changed are that we are now providing an alternative pathway towards screening and surveillance in patients who have visualization C. So we feel that we have new data that shows that in patients who have visualization C, the sensitivity for detection is lower. Visualization A and B, the sensitivity is maintained. But for visualization C, because the sensitivity is lower, we do feel that these patients are probably not the best ultrasound candidates, and an alternative surveillance strategy would be recommended. So we have a pathway for those patients. We also have shortened the short interval follow-up for patients who have ultrasound 2 examinations. Previously, we were recommending 2 years of short interval follow-up every 3 to 6 months. But we have accrued new data in the last several years that have shown that those patients who have an ultrasound 2 exam, their risk of HCC is not actually increased the way we thought it would be. And many of those subcentimeter observations turn out to not be HCCs. And so there's a couple of papers that have shown this. One was published in AJR by our group, and another was published by Amma Singh's group from UT Southwestern. And so we've kind of showed the same thing. So we do think that the 2 years of follow-up was not necessary. So we've shortened that to just 2 follow-ups. We've also incorporated the AFP into our algorithm. And then we also have stated that there is a preference for outpatient imaging in surveillance. And that is also because in patients who are ICU patients, ED patients, they're just not able to hold their breath or roll or do all the things that are required to have an optimal exam. Similar to mammography, you would not do a mammogram in an ICU patient for a screening exam. We feel that, for a surveillance ultrasound exam, doing it in an ICU patient or an ED patient when they're there for some other reason is not preferred. We recognize that some patients may not have an opportunity to have a surveillance exam, except when they come in for their, acute pancreatitis or whatever it is. So we're not making it absolutely not allowed. We give a little bit of leeway, but we recognize that those patients who are really sick, they're not going to get the best exam, and we don't want to unfairly label them as a visualization C patient when maybe if they were well, they would have a much better visualization score. So that is why we have stated that the preference is for imaging in the outpatient setting.
You mentioned about the introduction of the alpha-fetoprotein in the management for the LI-RADS Ultrasound Surveillance version 2024 as a criterion to indicate diagnostic CT or MRI. May you please explain specifically what when we consider alpha-fetoprotein positive? And another question related to this: can we use contrast ultrasound in these cases eventually?
Yeah. So in patients who have an ultrasound 3 positive exam, the recommendation would go to a diagnostic MRI CT or contrast enhanced ultrasound. But we have a special pathway for those patients who don't have an ultrasound 3 positive exam. So meaning that there's no sonographic finding, but they have an elevated AFP or positive AFP. And that positive AFP definition is defined by the American Association for the Study of Liver Disease. And we we incorporate that their definition, which is that either the AFP is doubling, increasing on 2 consecutive tests, or is greater than or equal to 20 nanograms per milliliter. And so that is if somebody has a positive AFP, but they don't have a sonographic correlate, they don't have an ultrasound 3 positive exam, but their AFP is high. So there's some suspicion that maybe there is a hidden HCC. That is essentially what that would be. The recommendation would be to go to a diagnostic multi-phase MRI or multi-phase CT exam. We don't recommend doing a contrast enhanced ultrasound exam in those patients who have an elevated AFP but no sonographic finding, because with contrast enhanced ultrasound, we need to be able to see it on ultrasound in order to characterize it with contrast with the microbubbles. So in that setting, CUS would not be indicated. But if you do have a positive finding on ultrasound, then CUS would be an option for further characterization.
So for our audience, I suggest you to take the document for the of the LI-RADS Ultrasound Surveillance version 2024 and just go to page 4, because there is what we are discussing now, what to do with the ultrasound 3 positive with alpha-fetoprotein protein. And I'd like to ask now Dr. Kamaya, can you please summarize this algorithm for us?
So let me just go through the algorithm very briefly. So, I did talk about this, but a little bit with the ultrasound 3 positive. So basically, you have an ultrasound exam. If you have an ultrasound 3 positive exam, then we would recommend diagnostic MRI, CT, or contrast enhanced ultrasound. If you don't have an ultrasound 3 positive exam, but you have a positive AFP, then we would recommend a diagnostic MRI or CT, but not contrast enhanced ultrasound, because again, if there's no sonographic correlate, then we would maybe it's hidden somewhere else, and so we would do a CT or MRI. If you have a visualization C exam, then we would recommend a repeat ultrasound within 3 months. And the reason for the repeat is that we have found that in patients who have a visualization C exam one time, they're still greater than 50% likely to improve on a follow-up exam to either visualization A or visualization B. And that's another study that we published in AJR that showed this. But if you have 2 or more visualization C exams, then you're much more likely to stay visualization C. So if you have a visualization C, so going back, we would recommend that repeat ultrasound within 3 months to determine whether or not you stay visualization C. And if you stay visualization C, then we would recommend consideration of an alternative surveillance modality. And so that depends on your institution and what is preferable to you. If you are at risk for repeat visualization C, then you can go straight to an alternative surveillance modality. And so that means patients who have NASH or alcoholic cirrhosis, child-pugh B or C cirrhosis, BMI of greater than or equal to 35 kilograms per meter squared. Those patients, you could just go straight to an alternative surveillance modality once you have that first visualization C. If you have a subthreshold exam, ultrasound 2 subthreshold exam, then we would recommend a repeat ultrasound in 3 to 6 months times 2. And so that's shortened from 2 years. And then otherwise, you would have an ultrasound 1 negative, and then we would recommend repeat ultrasound in 6 months, and that would be your normal cadence for surveillance examination.
Great. Thank you for summarizing all. And I'm really concerned for the visualization score C, because unfortunately, that's not that uncommon in some patients or in these patients. And we know that abbreviated MRI for surveillance has been discussed. There has also been, in 2023, a counterpoint in AJR discussing the role of abbreviated MRI for HCC with the extracellular or hepatobiliary agents. Would you recommend in these patients abbreviated MRI for surveillance? Or if not, what do you suggest in these patients?
That is yet to be determined. So I think that there's important research that's being done on this topic. It's really a point of contention, such that there is a counterpoint paper published on this topic. There are numerous debates, and unfortunately, I don't think I can give you a clean answer to that debate. We will have a surveillance abbreviated MRI working group that will hopefully tackle this question, which I think is really important. But at this time, if you do have a visualization C exam and you are recommended to undergo alternative surveillance, we mean alternative surveillance to encompass either a multi-phase CT or MRI or abbreviated MRI. We do think that it would be abbreviated. We do think that abbreviated MRI is the ideal alternative surveillance, but what that looks like is yet to be determined. And I also recognize that not everybody has an abbreviated MRI capability. Not everyone has access to MRI. And so that's another consideration is that let's say these patients who are visualization C, okay, ultrasound is not the best exam for those patients. I'm sorry, repeated visualization C, but they are now going to CT or MRI. Could they come back to ultrasound? How often do they need an MRI versus ultrasound? Those are questions that we really want to try to look at as well. I think there needs to be more research on that topic. If they were to stay on MRI, would they actually undergo those surveillance exams at the same way that they would do ultrasound? I think that MRI access is a question. If we were to recommend MRIs in all these patients, would they, if many patients who have larger BMIs, maybe MRI is a more challenging exam to undergo. And so if they're not adhering to surveillance, that may not actually improve survival. So, those are really important questions. The other important question is to understand what is considered to be cost effective. So when we think about a screening exam or surveillance exam, it needs to be cost effective. And if we are now recommending an exam that is more expensive or maybe has higher downstream effects, then it may not be as cost effective. So I think all of those questions really do need to be answered. There are some potential harms with surveillance exams. A lot of people have written about that. And it's not just with HCC surveillance, it's with any type of exam that may have some false positives. So, and just the mental anguish of undergoing all these exams and procedures, I think those also need to be put into consideration. So it's a really complicated question and complicated answer or non-answer at this time, but we hope to try to tackle that in the near future.
Perfect. Thank you for explaining why, I don't know, why we should do or we should not do. Thank you for explaining all this. And thanks also for telling us which are the future angle points for LI-RADS, what will be studied, what is being studied, and what will be implemented eventually in the next future. And to conclude, can you summarize again for our audience the major top level takeaways for this latest update?
Sure. So we have renamed ourselves from Ultrasound LI-RADS version 2017 to LI-RADS Ultrasound Surveillance version 2024. The category score and visualization score have remained the same. We now provide an alternative surveillance strategy for patients who have repeated visualization C exams or who are at risk for repeat visualization C exams. We have shortened the ultrasound 2 short interval follow-up recommendations to just 2 exams down from 2 years. And AFP is now incorporated in our algorithm.
Perfect. Short and complete. Thank you very much. It has been really a pleasure to do this AGR video article with you and to interview you. And congratulations for all your work. And thanks for our listeners to be with us for all these AGR video articles.
Thank you so much. Thanks for having me.